Thanks for coming. And it is lunchtime, but we'll have a lunch with some presentations, which will be great, because we are going to speak about a very interesting and innovative topic, that is transcatheter valve repair. So it's my great pleasure to co-chair this panel with Jeff Popma, and we have a group of fantastic players here. If I start from the left, there is a hybrid person, Francesco. He's a cardiologist. Marizano is a surgeon. And we have Georg Nickenig, who is a great interventionist. We have another hybrid person, Ralph Stefan von Bardeleben, because he started as an echo person. Now he's an interventionist, but still remembers about echo. And Nina, are you still echo?
Still.
Good. So, and we are going to address all these aspects. So, Jeff, could you please introduce the session?
Thanks, Alex. It's a pleasure to be here. My job is to open with what our objectives are for this session. We hope to understand how to perform better mitral repair in patients with mitral regurgitation. We have an esteemed panel for that. To learn the current experience and clinical results of the Edwards Cardioband system, and then, importantly, to understand how this technology fits into the broader-based technologies that we have available for transcatheter mitral and tricuspid valve therapies. We have a dynamite faculty. We'll be speaking about new solutions to the old problem of functional mitral regurgitation by Francesco. Dr. Nickenig is going to be giving us a more detailed look at the Edwards Cardioband clinical program update. We'll be hearing about the advantages of this system, a recorded case from Stefan. Advantages of the system as a treatment for mitral regurgitation by Azim Latib. And finally, I'll be addressing how we're going to put this into the clinical portfolio that we have available for us for treatment of mitral and tricuspid regurgitation. So with that, very quickly, we'll move on to Dr. Mazzano, who's going to give us new solutions to old problems. Francisco.
So welcome everybody, and I will start from the very basic. And I would like, my objective for the next few minutes is to state the answer of why are we here discussing about a new solution. So mitral regurgitation is, in most occasions, a functional problem. But regardless of functional or degenerative etiology, annular dilatation is one component of the disease. In degenerative mitral regurgitation, we have annular dilatation due to enlargement of the heart secondary to the volume overload. In functional mitral regurgitation, you may have a dilated and dysfunctional annulus as a consequence of LV dilation or as a consequence of LA dysfunction. This is also a highly underestimated problem in patients with atrial fibrillation. So whenever is the underlying disease, annular dilatation is a main component of mitral regurgitation. And as a matter of fact, annuloplasty is the most commonly performed procedure in open surgery. The need to establish alternative solutions for functional MR patients is absolutely fundamental. Medically managed patients with severe MR have poor outcome. And this is particularly true in the area of functional MR. Degenerative MR is still a surgical standard. Functional MR remains an uncharted territory where we can improve the way we treat patients. The common practice today in most countries is to approach patients with functional MR with a transcatheter approach first and using what is today the standard procedure, which is leaflet repair, mainly with a MitraClip system. Although we are all super happy implanters of these kind of devices, still the outcomes show that there is a substantial number of patients who are not responding to this therapy with residual MR due to the single component approach to mitral regurgitation. Again, mitral regurgitation is by two components. One is an annular component, and one is a leaflet/subannular apparatus component. What is fundamental to understand is that annuloplasty in surgery has been associated also always with durability. In those patients undergoing surgical repair without annuloplasty, there is a tendency to progression. This has not been, still today, enough underlined in transcatheter interventions, but if you look at the data carefully, you can see that there is a tendency to increase mitral regurgitation with time if you look at different papers. So this is one paper from Berardini et al. Showing increasing numbers of patients with mitral regurgitation more than 2+ at 6 months as compared with discharge. This is the data which comes from the Everest 2 trial, which shows progression of MR at 12 months as compared as discharge, and many others, including the work from Georg Nikenig, showing similar trends. Obviously, is it only because of annuloplasty? Maybe not, but for sure, if we understand that we are treating only one component, and by using a second component of the disease, we can improve our outcomes. We really have to think carefully whether we should scotomize, we should close our eyes and not look at this data. One component of the recurrent MR is the inability of acting on the annular dimensions using a leaflet approach. In some occasions, the reverse remodeling is also associated with some degree of annular reduction. And actually, in those patients who experience reverse remodeling, also MR is reduced as a function of the reduction of the annular dimensions. Again, if you look at the Everest 2 realism data, you will see that patients at 5 years' time tend to have increasing diameters. So the annulus dilates with time. And annuloplasty, as for surgery, may play a role to improve these outcomes. The fundamental question is the following. We all agree that a combined therapy will improve outcomes. The biggest challenge that we face in the next few years is, can we demonstrate that we can treat MR in patients with heart failure and improve symptoms and prognosis? And to be honest, I come here as a poor surgeon. For many years, I tried to demonstrate this with different approaches. Many years ago with a surgical ring, more recently with something different. I've never been able yet to demonstrate this because as you look at the data, the first data you see here, surgical versus medical treatment in functional MR, patients treated with annuloplasty versus patients treated without, with medical therapy, you see no difference no impact on survival. This is the data from Bolling, the original data from Bolling. Treating patients with ischemic MR has also been not associated with prognostic benefit. And last but not least, the data from the CTS trial showing similar results and even debating the role of annuloplasty. Now, these are the basic fundamental questions. But the other point is, what are the confounding factors which are determining these outcomes? As a surgeon, again, I've been trying to improve quality of life of these patients, which is the fact when the patient survives. Unfortunately, the risk of the procedure has been always pushing the indication to a later stage. So we need to work on early interventions. If we want to work on early interventions, we need to focus and concentrate our efforts in treating patients with devices which are leaving minimal footprint, and leaving the door open for all kinds of procedures. And in this regards, annuloplasty has the potential to be the leading methodology to treat functional MR as an isolated procedure. Another important feature that has been very well documented in surgery is that some of these patients which have been treated have been exchanged from functional MR to functional mitral stenosis. Increasing gradients, it is a limitation of current leaflet technology. We underestimate once more the effect of reducing the valve area by implanting multiple clips in patients who have a very severe mitral regurgitation and very distorted valves. So, once more, we need to have something to be able to treat patients safely, effectively, being able to treat early. And this is what we have now in our hands. We have a tool which is designed for this application, for early application of the concept of MR begets MR. Let's stop the vicious circle. So with this, the Edwards Cardioband system, I think you have been presented to this data several times. Is a device which has been tested in a CE mark trial on 60 patients, which are functional MR patients. These patients have been treated with a surgical-like annuloplasty, which has been consistently reducing the annulus by more than 30% and creating a reduction of the septal dimension by an average of 28% by core lab. This has been shown to be effective early and durable over time and has been associated with a reduction of MR, which is at least comparable with what you can obtain with surgery, if not better than what has been observed in the CTS trial. This has been associated with relevant improvement of functional symptoms and quality of life, and therefore setting the stage for a new procedure to solve a very old problem. Thank you very much for your attention.
Francesco, you can take them here or up there. Why don't you just take them up there if we can? We got a couple minutes for questions. Please feel free to use the time to react, ask some questions. I'll see if the panelists have any. If not, let me ask, help me understand this better, because you're the perfect person as a surgeon to help. There is a lot of controversy about whether repair or replacement is the optimal therapy when patients go to surgery. I think it's still controversial in terms of durability of the results with the repair. And now we have a number of different options available to us for a transcatheter. Can you give any insights into whether or not you think a fully replaced mitral valve, placed by transcatheter means, versus an annuloplasty and probably leaflet ligation in some cases, will be the optimal for long-term durability?
Well, I don't want to answer the question directly. I think we always ask what, we should ask when. I think it's a matter of patient stratification and patient selection. It is obvious that most of the patients we're treating today are so end stage that repair approaches may be not so effective, and also the objective in these particular patients is mostly a palliation. We want to improve symptoms, but we can't improve prognosis. On the other hand, if we can produce a device, if we can implant a device which has a minimal footprint, which leaves the door open to other procedures, which may be effective, and it is demonstrated to be effective in patients with non-extreme dilatation of the left ventricle, improving quality of life in this category of patients, we have a potential to demonstrate prognostic benefit. I mean, we have now a unique opportunity as community to change practice. Till now, FMR has no guideline-oriented indication. With this device, we have a potential.
Azim.
So, Francesco, if you look at the surgical literature, and people often say this to me, that undersized annuloplasty for FMR is associated with a high recurrence rate. Although we contributed to the data for Cardioband, and we're not seeing that high recurrence rate. I mean, why is there a difference? Is it just not long enough follow-up or not enough patients?
Well, the length of follow-up is the same as the one reported in the ACHR trial. I don't think it's fair to make a head-to-head comparison between two populations which are not comparable. The surgical patients have been also revascularized. So in theory, they're even, I would expect even better results with surgery as compared to this approach, which is done in patients who have not been also revascularized at time of procedure. I think there are two components that may underline the better outcomes that we've been observing. One component is probably the fact that we have been able to adjust the amount of reduction of the annulus by acting on a beating heart. And this has two components. One component is that we see how much we need to decrease the annular size to obtain coarctation, but also in the latest phases we've been seeing that sometimes too much reduction is counterproductive. So this is what we do. In surgery, we close our eyes, we implant a 28-millimeter ring in every patient, and therefore, in some occasions, we create the so-called frozen posterior leaflet. The other condition that makes this procedure different from surgery is probably also intrinsically related to the way that the annuloplasty band here is implanted. Actually, different from surgery, we implant the ring at the base of the ventricle. We're really screwing into the ventricle. We are reducing the base of the ventricle. This is not what you can do in surgery. In surgery, we never put sutures in the muscle.
So, Francesco, we've got one 45-second answer, if you can give us a question from the audience. In FMR, what's the role of surgical mitral valve repair when replacement can facilitate mitral valve and valve at a later time?
It's a great point. I think well taken. I think as a surgeon today, you need to be very careful to understand the platform for future options. I think in surgery, there are very few surgeons today who are still repairing valves in this field. And I'm very sorry about it because I've been investing so much, but I think it makes sense.
We spoke, we discussed, but now we have to see something. We have to see a case, and Ralph van Bardelben is going to show us a case of Cardioband mitral valve repair recorded from the hospital in Mainz. So, Ralph or Stefan?
Eric, thank you very much for having me, Jeff. It's my pleasure now to come back from the tricuspid space to the mitral space. And it's very nice that you heard that this may be a little bit more complicated, but I tried to show you how we can do this and address this in a far more simple situation. We've already seen a very nice introduction by Francesco Maisano, and I would like to highlight that we actually have three different diseases. We have to subdivide functional MR basically by the dilatation of the ventricle or the atrium, which has no tethering of the posterior leaflet, which is ideal for a direct annuloplasty. And there's the yellow traffic light, which shows us patients that may be a little bit more problematic for simple annuloplasty, which may need additional at the time of intervention or in a stage procedure after 1 month, 1 year, 3 years' time, also a leaflet treatment to overcome the tethering, especially in regional ischemic functional mitral regurgitation. And there are other etiologies that we addressed this morning. So one of the ways to further understand an interventional approach, the valve, is of course the use of either three-dimensional echo that you will see throughout this procedure, or the use of CT images that are used anyhow to plan the procedure. And there we come back to some surgical experiences that the most efficacious partial band is done from trigone to trigone. And as you can see in this analysis here, in the pre-planning CT for a Cardioband analysis, this is automatically done by the computer, giving you the left and the right trigone and giving you the end of the commissures. And what I like to do and to show you is that I just implant also the hinge points, and I can control them here in a long axis view, either in a two-chamber view, in the dilated heart, as you can see, but also in the long axis view, the hinge point between the leaflet coming into the annular fibrous tissue and also of the beginning of the left ventricular myocardium, where we actively place the anchors. So I want to present you this case of a 79-year-old female, so almost an octogenarian, who had a worsening of symptoms. She had fatigue, dyspnea. She had a New York Heart Association class already 3 to 4. In the past, had known diseases with a moderate MR that was aggravating. She had some AR. She had a history of a stroke, permanent atrial fibrillation. And as you've seen also in the tricuspid space, that there were almost 91% of all patients had atrial fibrillation and also enlarged atria. Arterial hypertension, mild coronary artery disease without any relevant stenosis in this patient, and the logistic Euroscore was 23, and the STS score for mortality was 7 in this patient, giving her a non-low risk but rather high risk situation. I would like now to go into the planning area and to look a little bit at the situation of this patient, and these are the moving images, and you can see that there's a pseudoprolapse in the middle of the valve, which is quite typical for some tethering. We can also see D, which will be changed to 4 to 5 centimeters. So 5 centimeter changing is the maximum for this device. And you can nicely see that we will implant 15 anchors. We have a close proximity of the great vein and the beginning of the coronary sinus in the first 3 to 4 anchors. So this will be difficult, but the landing zones seem to be nice. These are the pre-planned angulations that we will also control in our fusion system. Here we see the initial transeptal puncture, which is important for this total percutaneous approach. We will go in a bicaval view and puncture about 1 centimeter from the muscular part. We will go about 2.5 to 2.7 centimeters posterior to the end of the aortic root. So this will be done in short axis by echo. And then we aim for a height which is relatively high for a cardioband procedure, which will be about 4 centimeters above the AV in a 4-chamber view. So these are very important landmarks in order to guarantee the maneuverability. We see the extravision system, it's a fusion system. Here we see that we get different angulations, and we now start with the procedure. As you can see here, we first align the heart in the CT. We're now in the aortic root. So we now have an injection phase of 10-15. For the calibration purposes, we use a magnification. We depict the pigtail in the aortic root, and I now do 2 calibration steps in RAO and LAO projection. We now take a 0.032 wire up front to the superior caval vein, now the dilator. We pre-dilate slightly the excess. So we now have a long Abbottson jute sheath that will enter the right atrium. We pre-bend the needle slightly in order to accommodate a better tenting. In the biplane view on the left-hand side, I'm tenting the muscular part. I'm getting posterior already in the muscular part. So what you've seen there was that we used actually the pre-CT planning, and I just hold this image for a second, that we used this also for the transeptal puncture. I'm sorry, I'm just one going apart. I'm just going here into the septal puncture. So we're using actively the CT planning to align perfectly above the commissure of the septal part of the mitral valve in order to reach all different areas of the annulus. This is the pre-band needle that goes in a sheath and dilator back to the fossa ovalis, which is depicted here. So we will pass the muscular part by about 9 millimeters, going to inferior. And here we're already perfectly about 2 centimeters, 2.5 centimeters away from the aorta for this puncture. Part. I'm getting posterior already in the muscular part from the wall, yeah. Okay. Getting better. I'm moving slightly up front. 0.7 to 3, we're Happy? And to the outer wall, that's it. That's 3 centimeters. Measure again. We should be near 4 then. 4. 3.8, 3.9. Exactly what we wanted in CT. I would puncture here. See that? It's perfect. Okay, we go through it. Stay in this position. We do a 3-dimensional puncture. Okay, you stay there. So you see the commissure here. I just removed the sound. You see the commissure here. You see the needle here. So we're puncturing directly over the commissure, which gives us extremely nice durability throughout the whole annulus of the mitral valve. And you can see that this can be easily done under 3-dimensional imaging. Now we see a stiff wire in the left atrium, and we exchange for the 24 French delivery system. Now we begin with the procedure itself. This is the 24 French delivery system. We keep on without any sound, and you can easily see that the V wave was very high. We now put the stent on the a little table that's placed above the femoral of the right leg. We measure, of course, also the pressure in the atrium. In this specific case, it was between 25 and 30 millimeters of mercury. We go in with the system, as you see nicely here. And this is the combination of the guide catheter that you see until here and the implant catheter. That's the inner catheter that delivers the band. This up here is the spool that will later take up the metal wire to shorten the whole band. So this is the first position. You see, we reach the trigone. Here's the left atrial appendage, and I try to be superior and so anterior to this situation. I control the mobility of the spool and push the system very, very much anterior. So here's the commissure, and here's the trigonal point of this valve. All the implants are being controlled in relation to the leaflet, as you can see here on the right upper image. You can nicely see that we're able to see in a cut plane in echocardiography not only the hinge point, the insertion point of the leaflet, but also the vessel and the landing zone, which is between the vessel and the hinge point of the leaflet. Now we're screwing in the first anchor, which is next to the ostium of the left main, and then we're moving backwards. On ECG, we control for extrasystole. If we have extra beats, we know that we reached the left ventricular muscle, and this is a very good basic electrophysiological sign. So we use fluoroscopy, we use ECG, we use 3-dimensional echo, and a little bit of fusion, at least in minds. As you can see, the system is capable of doing cut planes and any angulation of the catheter at any point of the annulus throughout the procedure, and this is very, very fast. Again, a normal 3D image, and you see the band starts very, very much anterior. And here we control that it's very, very near to the green point, which is the left trigone. Now we have an en-face view. As you can see, this is the mitral valve in fluoroscopy in an LAO caudal, and we now just start to place the anchors from this trigone to the P2 segment. There is a torque control of 2.3 Newton meters here, and now you see we're implanting, and you again see the extrasystole. You see a little pause, then you see ventricular extrasystole. Later on, you will also see couplets or a short run, and this is a very good sign that we reach the muscle. We also control in between also the coronary artery. This is especially true for the circumflex artery, but you see that we nicely can control the vessel here in 3-dimensional echo. The dark spot here is the circumflex artery. We can control the ring position. We get a 3-dimensional view, and we get the same in fluoroscopy. So a very safe and very controlled procedure. So we go on with the further screws. I'll now show you a stage that's a little bit later. It's on the P2 segment. So now we're treating the posterior segment. You see that already about 6-7 screws are in. We can nicely control them in echo. You also see them as little teeth in echo. Here you nicely see the vessel above. You see the hinge point the catheter position, which is ideally 45 degrees, and again, next anchor is implanted. So as you're running through the posterior segment, especially as Azeem Lateef will point to it, this area is very easy because you simply pull out the system, you go every 8 millimeters, you keep the same position of your catheter, and you just screw in the screws in 2 minutes. So screw from or anchor from anchor is about a 2 to 3 minute action in this procedure once you get used to the system. Now we have done almost 40% of the circumference. You can appreciate that I'm extremely near to the aorta. So the band is starting here, and I'm now in the middle of the P2 segment. And we are further continuing with screws. You can nicely see how we can turn the three-dimensional echo image, and you get a nice appreciation of the height of the band and of the different positions of the catheters. So this is the situation when we reach the final anchor. You can nicely see the symmetric approach that actually totally follows the yellow line, which is the annulus of the mitral valve derived from CT. And this is superimposed into the fluoroscopy, and you can appreciate the very, very nice symmetric shape of all anchors. And also in three-dimensional echo, if I just stop it here, if you just appreciate, I'm sorry, just a little bit back. If you just appreciate here, we reach a 75% circumference of the mitral annulus. So this is at least as good as a Futura band implantation in heart surgery. I think you can all appreciate that. And now we will begin to do the annular reduction by entering the size adjustment tool, and this will be done now. So I'm retrieving the system. As you can see, there's a hemostatic control here, so we can simply pull it out. You will see me holding here a little wire. You see it blinking here. This is a little metal wire that controls the connection to the spool. And now I'm adding the size adjustment tool into the system. You see the whole band deployed. And now we will do the cinching under full hemodynamic control, V-wave control, and echo control. And this is the difference to a water probe in surgery. So I'm starting to cinch here. I'm activating the system. You see now that the screwdriver is actually connected to the spool. You see it on the lower right image. And now you see a detailed depiction. This is the regurgitation. As you can appreciate, it goes all along the whole area. Sometimes we already see an effect if simply the band is implanted. And you can now see that we will change the regurgitation by reducing the annulus size. Now I have here a control. We will see the centimeters next to my thumb. So we're just going at the moment from 1 centimeter to 2 centimeters, and we get to a basic position at 2.5 centimeters. We have hemodynamic control. You see that the band begins to cinch, and just correlate the position of the anchors to the yellow line. So it's very easy actually to control this here under this CT image that is superimposed, and you can appreciate that I'm moving now from the yellow outer line to the inner line, which is the posterior leaflet. So this is basically the same a heart surgeon does when he puts the posterior leaflet anterior. And you can also appreciate that the MR is beginning to disappear in the right upper image. If you look at here, at the LA pressure, it's 22, the V-wave was 40, and please remember those measurements. And we came down from 50, and now I'm cinching, and you see it drops to 21, 19, and the LA pressure gets down to 10. So this is a reduction of 15 millimeters of mercury within 8 minutes, just by cinching the band. And I think this is traumatic. We see this beating hearts. We don't change any inotropes. We don't change any conditions. So we have the possibility to have pre and post within 8 minutes. And if I'm over cinching, I can release the band. And please appreciate up there, there's no regurgitation anymore whatsoever. And I just replay this for you. So please look at the upper right image. This is a trivial to non-MR. It's a surgical-like result after 63 minutes annuloplasty implantation. So this is the final discussion with the heart surgeon. Annuloplasty plus chordal support. But as we agreed in our discussion, Andrea, Christoph, Andres, we achieved a beautiful result with almost trivial to nil MR after a reasonable chinching to 4.5 centimeters. So with a mean LA pressure that dropped from 22 to 11, I think we were very effective, over-effective. So we stopped the second part of this procedure.
The anchors were very deep into the ventricle, so reducing and modulating the morphology of the annulus. So I really think that in a patient like this with a very high risk Euro score, the result is beautiful.
I will now push forward the blue here, and we will release the whole system. So we're done. LA pressure still is 10 to 12. Moves out. Perfect, that's it. We detached, I removed the system. So you see the pressure is 10 cc's of mercury. I'm out. I go out of the atrium. A little suture, so the excess is 8 millimeters. I do a double set suture, and that's about it. You don't need any closure device. You will see there is no bleeding. You see a very nice situation at the access situation. We have no MR at the end, so if we have a short look into echo, a beautiful result. 0 MR, 1 annular plus T. I think the best possible result we could achieve. Thank you very much, and nice greetings from the University Center of Mainz, Germany. Thank you very much. Thank you. So my take-home remarks would be that percutaneous mitral annular repair nowadays in a transcatheter-based version is fast and feasible. The device time in this case and the transeptal puncture took 1.5 minutes. The device time thereafter was 63 minutes. 3D imaging, though, is important for the procedural success. You've seen that we can control nicely the position next to the left and right trigon, and we achieved a complete annular repair. Implant catheter, IC, coronaries, the circumflex, and the hinge point to the leaflet are the 3 key structures in this procedure. Success is controlled under normal hemodynamic conditions throughout the whole intervention. Thank you very much for your attention.
So, thank you very much, Ralph, for this fantastic presentation. In point of fact, it is the fastest cardioband I've ever seen.
Yeah.
It was also my fastest cardioband, I have to tell you. I was lucky to do this under a film team, but
you know, Ralph, it didn't come like that. And I'd like to ask Francesco. For Francesco, you are the inventor. Can you tell us what were in your mind the main steps of the improvement of the procedure?
The main step, there have been several steps. What you see here now is the simplicity of the procedure. The procedure has been very streamlined and simplified. I would like to also mention that in the future we will have a lot of fusion imaging, but you can do this procedure without fusion imaging. Let's be very clear. You need a reasonable setup, which is the same setup that you use for mitral clip. The only difference is that you need, we do a CT scan. This has been something which we have been doing to plan procedures. I'm not sure we're gonna do CT scan in the future, absolutely, although in general, I think the trend in patients with FMR will be that CT scan will become standard practice to rule out different options, including replacement. So we had 2 moments of the evolution where we were stuck. One moment has been to achieve proper imaging. And the other time where we were stuck has been after the first 15 patients, we had some evidence of anchor detachments, and we were a little bit stressed. So the 2 things are also kind of combined. Today, anchor detachment does not happen anymore. We can control each anchor implantation with, like you, Stefan, showed, with a very standardized and sequence of feedbacks. We have obviously we have the evidence of angio of the anchor penetrating the tissue, just like you do for a pacemaker lead. We look at the EKG changes. We see very often premature beats from the ventricle because the anchor goes in the ventricle. We see tactile feedback, and we do this under echo. So everything really under control, but obviously it has been an effort that took some time, and this effort is not finished because I think we're still learning. I mean, we're very proud to have people like him that can do it in 60 minutes. Not everybody can do it in 60 minutes at the moment, but I would like really to emphasize that this procedure is not difficult. It's easy. To some extent, it's much easier than a leaflet intervention, where the knowledge base to take intra-procedural decisions can be very complicated. In this particular case, like you nicely showed, you are just implanting the device in position and then cinching, you obtain the effect.
Okay, thank you, Francesco. Now a couple of very good questions from the colleagues. One we can deal with very fast, and Ralph, you answer. Do you think there is a need for a specific transcatheter training for this procedure, or is it really very similar to the mitral clip procedure?
Oh, it's extremely similar to the mitral clip procedure. Actually, we don't have to be as precise as a CT pre-planning because actually you slip a little bit. So you've seen I made changes of about 4 millimeters. That doesn't affect at all the procedure. I think it's basically like a mitral clip transeptal puncture, and this can take 1 up to 5 minutes, but actually no more.
Okay, a question for you, Azim. Do you have to protect the circumflex with a wire during the procedure?
So I think in probably most cases, no. Even in cases where the circumflex is pretty close, I think with experience, you can actually push the tissue away and push the artery away and find an area to put your anchor in. Although the wire in the circumflex, if you have a nice dominant circumflex, can actually be a very good angiographic marker. And you can use it, to guide your navigation on fluoroscopy. But we haven't been routinely protecting the circumflex.
Another question from a very friendly colleague to Francesco. Francesco, you've seen most of the case, you've done so many. So is there any way to unscrew one of the screws if there is an issue? Is there a problem?
So each individual screw is delivered with a torque cable catheter that is holding the screw in place, and you can reposition several times. You can retrieve the screw several times until you release it. So what we do in case of difficult locations, we like to check on echo, maybe on angiogram, whether this anchor has been implanted in the wrong position. And before releasing the anchor, we discuss. But basically, again, this is a very rare event. And in case you, for instance, puncture the circumflex artery, which is something that should not happen, but it may happen, and I would say it would happen to everybody doing this procedure at least once. The good news is that usually this is a puncture. So in most occasions has no consequences. But still, this is one of the key elements of this procedure. You have to implant the anchor between two landmarks. One landmark is the circumflex artery. The other landmark is the hinge point of the leaflet. You have to go in that space for each individual anchor.
Absolutely, and you can also get tactile feedback because you have pressure in the coronary, and you can actually use it to get into the landing zone. So there are different catheter techniques to go for that, actually.
Okay, a question for you, Stefan. Do you use oral vitamin K blockers or DAPT after Cardioband?
I already mentioned that the patient population undergoing this procedure has a high prevalence of atrial fibrillation, which will answer this question for the majority of patients already. It's about 60 to 70% here. It was shown 90% in tricuspid repair. The rest is done with dual antiplatelet therapy in our institution for 3 to 6 months.
Okay, now I'd like to ask to Azim and to Ralph, what about the learning curve? can you give just a feeling? You are a very experienced mitral clip operator. Azim is a very experienced structural operator. Can you tell us when it happened? When did it happen?
I didn't start with 1 hour procedures. So I started with 3 hour procedures because you have to, with the first procedure, I tried to reach different parts of the mitral annulus. So I pre-tested actually the mobility of the catheter. But I think after 5 procedures, you get very well used already to the system. So if you know how to do a leaflet edge-to-edge therapy, I think the learning curve is about 3 to 5 procedures. That is already sufficient. It's a very steep, very fast learning curve. And the first thing is that you can manipulate the catheter better. And the second effect is that you get faster. So I would say you get faster after 10 procedures. You get very experienced and very confident after 3 to 5 procedures. Seem, what's your impression?
Yeah, I think very similar. I think if you have mitral clip experience, then you already have the experience of the transeptal puncture and how to do that. I think the learning curve is shorter, though, in comparison to mitral clip, because every cardioband is the same. So you always start on one triangle and you go to the other. It's always the same. And there may be some technical challenges of an artery or vein close by. Not every mitral clip's the same. You need to make decisions as you do the procedure. You may need to change the position of the clip, 1, 2 clips, and the first clip may have an impact. So I think for me, the learning curve with mitral clip is much longer in comparison to this.
But I think there are 2 areas where actually implanting the anchors is a little bit more difficult. And this is the first 3 anchors that are vital for the mechanical support of the band. And also, I would say, the less septal anchors in the hooking part. So there are differences in the procedure. But I agree with you that the learning curve is extremely steep.
Okay, so thank you very much, Stefan. Great talk and a great discussion. Now we saw that it works, but Azim is going to tell us if there are any advantages of this Cardioband system as a treatment for mitral regurg in comparison with others.
Thank you, Alec and Jeff.
Be objective, huh? Don't be biased. Huh?
Well, actually, what I'm going to do is maybe a little bit different. I'm going to show you some cases where I think these cases may highlight why an annuloplasty system may be better for a lot of patients with functional MR, and also how, as we've gone along using annuloplasty, a little bit we start to treat even slightly more complex patients and thinking about how we can do maybe fully percutaneous repair in our patients. So I'm going to do this very much, these are my conflicts of interest, very much case-based. I'm going to use a number of cases from myself and from George Nickenig to really show you what we've learned over the last couple of years implanting Cardioband on the mitral. So the first case is a patient that George treated. This was part of the initial study, so part of the CE mark study, and so data very well collected. Again, patient severe MR, normal ejection fraction, lots of comorbidities. And as you saw, CT is really useful in trying to decide and planning the procedure. It really helps you plan as well as guide the procedure and decide on how many anchors you're going to implant and where you're going to implant those anchors. So here was the procedure done, the implant size reduced. We'll see if this runs. And here you can see the implant before, and you can see the contraction after. There's a bit of, it's running a bit slow, but I think you get the idea. And here we'll see the MR, and you see how the MR was severe initially, post-procedurally reduced really to trivial MR, or mild MR, depending on how you define that. 1 year later, still a good result, and then 2 years post-procedure, transthoracic echo, still showing a sustained good result. And that's not surprising. We saw this in the data as well. From the initial CE mark study, one of the most surprising parts has been when we took paired echoes for the same patients, and we saw that at 12 months, this is the data at 12 months, there's data coming out at 24 months as well, that there's a sustained reduction in MR. I think some of that is, like Francesco mentioned before, is the fact that we're also putting these anchors into the muscle. And so we may be having some effect on the basal part of the left ventricle. Here's another case, this is a case we did in Milano, and I think it shows why transcatheter options are really superior sometimes to surgery, because we can make our decisions really at the moment on a beating heart and assess the result and titrate the result based on what you see. So here, severe MR On baseline, we put in 15 anchors, and here was, after 3.5 centimeters contraction, I'd say pretty good result. We could probably stop there. The great thing with Cardioband is that you can decide, what, let's even see if we can contract the annulus even more and actually completely get rid of the MR. You have the option that you can then go back. So if for some reason we've never seen a gradient so far, or mitral stenosis being caused by Cardioband, but if we were to see it, or if we were to see that the MR got worse with increased titration, we could even go backwards and take off some of that cinching. So I think the ability to fully adjust forwards and backwards the cinching of the beating heart is an advantage too. When we initially started doing Cardioband, part of the study, any patient with annular calcification was excluded from the study because we really didn't understand how this device would work in the presence of annular calcification. So some of my colleagues, and this is a case from George, have gone on and started pushing those limits. Obviously, you won't do a patient with severe MAC, but in this patient, for example, where you do see there are degrees of annular calcification, and on CT, you can also identify that close next to the annular calcification, there is tissue that you can use to anchor. You can start now pushing a little bit the limits with Cardioband and treat patients who do have annular calcification too. So here you see the baseline echo in this patient. Years before the device is contracted and there's reduction of annular dimensions. This is after cinching, and you can see marked reductions of the MR despite the fact that there were numerous spots of annular calcification. One of the other cases we've tried to do, we've had some patients who, despite good results on mitral clip, have come back. They've had leaflet therapies, where often maybe the main mechanism of MR there was predominantly annular dilatation. So this is a patient, a 74-year-old patient we treated, was sent to us a year later after he had had 2 mitral clips inserted in another center. I don't have the original echoes, but looking at his notes, it said that he had a really good result post-procedure, so mild MR post-procedure. A year later, his annulus was larger, and now he had recurrent MR. And this is something we see sometimes with mitral clip. And the problem now is that there are multiple jets of MR. There's a jet between the 2 clips and on either side of the clip. This becomes really difficult and challenging to think of how you're going to treat this with other leaflet devices. Certainly, we can't do transcatheter mitral valve replacement. So what we decided to do in this patient was attempt a Cardioband and see if that would have an impact on his MR. So here's, you see the 2 clips, you see the Cardioband, and this is the, the baseline and final results. Sorry, just go back. I'm going to show you that this is actually not running. Okay.
It is.
The last case I want to show you, and I think as we start moving forward and we start thinking about the mechanism of, mechanisms of MR, we need to start thinking about maybe in some patients they have annular dilatation as well as excessive tethering. And so we may need to think of combined procedures. So this is a patient who's 66 years old, ejection fraction of 37%. The MR was severe. Let's see if we can make that run again. Unfortunately, it's not running, but so you'll maybe have to believe me. I'll try and run that again. There you go. So severe MR, lots of annular dilatation, and as well as tethering of the leaflets. So in this case, we thought we'd try and do a fully percutaneous repair. So we'd go in, do a Cardioband, but be ready to also do a leaflet therapy if needed. So this was the Cardioband. It was guided by fluoroscopy and echo as normal. You see we implanted the Cardioband over here, but the result after the Cardioband, there was still residual MR. So we decided to implant 2 clips, one initially slightly medially and the next more laterally. And this is the result after 2 clips and a Cardioband. So here really doing a surgical-like result. We have a Cardioband plus 2 clips, very similar to what Maizano did with doing an edge-to-edge as well as annuloplasty. You see that here also on the 3D. So here's the final result in this patient 3 months later, still really residual, trivial MR. So I think with Cardioband, you can start thinking of it as a first option in patients, but knowing that the fact that it does leave options open, you could do a fully percutaneous repair. So I think the key messages I'd like for you to take, I think Cardioband has become a standardized and reproducible procedure. I think some of the advantages for me are that we are seeing durable and sustained reductions in MR, with future percutaneous options being left open. So you can do an edge-to-edge as well. I think the full adjustability of a surgical-like annuloplasty on a beating heart is important. As we've gained more experience, we are doing cases with increasing complexity. So cases where initially we thought may not be good candidates, either because of spots of annular calcification or because a coronary artery or coronary vein was very close. I think it may be an option for patients with recurrent MR after mitral clip if annular dilatation is present. And I think with the devices we now have available, complete percutaneous mitral valve repair is now possible. Thank you very much.
So, thank you very much, Azim, for sharing with us your very large experience in the domain. So I'd like to ask Nina. Nina, you are a great expert in echocardiography in the mitral domain. So in your opinion, who are the patients where we should not go with a Cardioband? Easy question, huh?
Very easy. Okay, let me answer the question the other way around. So I would include all patients with pure functional mitral regurgitation as long as they don't have a very severe retraction of the posterior leaflet, because this is something we can make worsen. So if you close the band and we can see a really severe retraction of the P2, P3 segment in some patients. I wouldn't exclude, as you very nicely showed, patients with mild calcification, because especially if it's spotty calcification, you will find patients where you can screw in. I wouldn't also exclude patients with degenerative mitral regurgitation and annular dilation, because as you've very nicely shown, so we can combine it, and it's also possible to combine it in one procedure. You just have to think about how to stage your procedure. And I think if you have a Cardioband in place, you may go for a second procedure, but it's much easier to put another device in when you didn't cinch already, because you see more of the posterior leaflet, it's longer, so it's much easier. So I would also include patients with a dilated annulus and a localized degenerative disease, which can be treated with an additional device. So, and I think we are at a stage at the moment where we are just learning what kind of morphologies can be treated. And I think there's a broad spectrum, and we are still learning, so we are not at the end of morphologies we can treat.
I see that Stefan is willing to answer the question. He was shaking a little bit, so we have to take care of that.
I totally agree. I think different forms of leaflet therapy combined with annuloplasty and degenerative disease is an ideal future field. It's not something you can do with annuloplasty alone, of course, but Francesco has nicely demonstrated that the combination with leaflet edge-to-edge Alfieri technique works. We've shown this morning a combo case of first use of chordal replacement, transcatheter-based, combined in one session with Cardioband. So this opens up degenerative disease treatment in the elderly and later in the younger that's completely surgical-like, and the two access points are just 8 millimeters and 1 centimeter large. Beating heart, off pump, no foreign blood given. I think this is a huge improvement for the future. So I also think that the big future increase will also be degenerative disease for repair, because these procedures are so safe. Patients don't die during the procedure, and mostly not at 30 days.
I have a question. Oh, please, go ahead. Go ahead.
Well, my question is to Francesco. Do you have to have annular dilatation for this to work? It seems as if it works even without marked annular dilatation, or is it something we should be measuring in every patient?
First of all, I would like to ask you, whoever wants to answer this question, what is annular dilatation?
Right.
Yeah, so there is no such disease.
The panelists are not allowed to ask questions to the chairman. That's right.
So first of all, we don't know how to define annular dilatation. I rather prefer to use the annular to leaflet mismatch to some extent. Anyhow, it's obvious that a patient with marked annular dilation as a primary mechanism of MR is the kind of patient who will respond better. And if you treat a patient where the annular component is minimal, you may induce only a frozen posterior leaflet. Having said that, the old mechanics behind this active cinching are still unknown. We have seen patients which on paper were contraindicated for annuloplasty from a surgical background who had fantastic results. I always say the first in man we did in 2013 was a patient with the ischemic MR, asymmetric tethering, very asymmetric jet. This is a patient that by CTS trial would be the typical patient who fails, and he's still mild MR 4 years later.
I may ask you to follow up to Stefan and to Francesco, but still today, if you see a patient with really very asymmetric MR, functional MR, are you willing to start with a cardioband, keeping the mitral clip for afterward, or are you willing to start with a mitral clip?
I think the younger the patient is, the more I will go for an annuloplasty. And I would generally go more for an annuloplasty as a first treatment option because I have more different options open. I think mitral clip is a wonderful device, and we all have big experience. Francesco has it, I have it. So mitral clip is an extremely nice bailout situation, and it's an additional factor for ischemic tethering. But you can do a lot of patients without, and you can do a lot of patients with pure annuloplasty, and you keep the option of a percutaneous valve implant open and multiple further issues that may be there, and including LVAD therapy and all other therapies. So the younger the patient is today, I would say the more annuloplasties you should use because you have secondary repair options. And you can have all those 80, 90, 95% where it works. They stick with the annuloplasty, and those 5% or 10% where you need something else in 1 year or in 3 years' time, you can add that only for those patients. So I think the footprint is really, really small, and it's a great work that Francesco has done on this device and on the whole development there.
Francesco, you want to add something?
I cannot agree more. I would like to go the next step. As we have this device available, I change a little bit my strategy in leaflet repair. We've been treating patients with multiple clips, trying to entertain a fight against a very distorted valve anatomy, and in some occasions we modified the physiopathology from mitral regurgitation to mitral stenosis. This happens much often than we think. And today, I think having this tool in mind, if you have a patient who's not responding after 2 clips, we should be very reluctant to put a third one and think about follow up the patient, and if he doesn't recover, go for a combination.
We now have a series of 40 patients where we did this combination. I could no more than agree because the mitral clip focuses on a pulling force in the A2-P2 region. And functional MR dilates in all directions. That's what we know from the tricuspid, that's what we know from the mitral. To treat both the medial and the lateral commissure at the same time is not achieved by a mitral clip implant, even though mitral clip is very good. So what I also do is I adapt also the intercommissural parameter and distance. That's something nobody looks at. So the distance in the 60-degree TE view has also to be adapted by the annuloplasty, and then you do just 1 or 2 clips and everything is perfect. The patient goes out with a mean gradient of 1 or 2, and this for a very, very long time. I think this is a very good concept to go for, especially in ischemic disease.
Don't you think that having the cardioband available will increase the number of clipping because more patients could become candidates? Don't you think?
Maybe, but I think maybe. I think the important consideration we have to understand that we have been pushing the limits of leaflet repair in some because we had only that, and now we have to think differently. And the best case example is a patient like one of those patients that you just showed, with functional MR, very broad MR jet. You start with a clip in the middle, and then you have a jet on the side. You put another clip on the side, and then you have jet on the other side. You end up with 3 clips. Maybe you want to put a 4th one. And what happens as soon as you go away from the A2P2 region, now you start pulling on the subcommissures. You open the clefts. And so you're really working in the wrong direction. These patients probably would be ideal for combination.
Okay, I have a question for you, coming from the colleagues who listened to you, and they saw you yesterday doing this valve-in-valve, fantastic thing, and they ask you, Azim, do you think we could put a sapien into a cardioband? Azim.
I don't know. I mean, it is only the posterior annulus. Theoretically, it could work, but I don't know. Maybe, Francesco, have you ever tried it?
So we've done some annual work, technically feasible. Honestly, the experience with posterior bands is not so good. So I would say no. And I don't think we need to, and we have alternatives.
What if you had an aortic valve as well? So a
that's a good
TAVI
point.
valve in front anteriorly, plus the cardioband. Would it work then?
Yeah, you did it for Mac, huh? You put the core valve, I remember, in the aortic position. And
So this is a possibility. So one of the problems with the pure MAC, or also the cardioband, is that your support is only from the sides and from the back. So what happens over time, and this is also the Munich experience, is that there's a shift towards the LVOT. And those patients get subvalvular stenosis, and they can also die. So the mortality is not nil. It's about 30 to 40%. But if there's a TAVR valve in the aortic root, you have a game changer for that, because this gives you also support in the anterior side, and then it could be an option, but I'm not promoting it actively here.
So the answer is no. You
the
can't.
answer is no. So thank you, Azim. Thank you. Great talk. And now we'll have to step into the future, because, we are in the middle of the afternoon, and we have to step into the future before leaving the room. And Jeff is going to tell us about the clinical consideration for the Edwards Transcatheter mitral and tricuspid therapy. Please.
Thanks. I think the job for me over the next 10 minutes or so is to show a very broad portfolio of Edwards transcatheter, mitral and tricuspid valve therapies. And Francesco, you were very careful to not answer this question, and that is, which of the devices is going to be best for patients who have mitral regurgitation? Now, the annular reduction we've talked about extensively is primarily for functional mitral regurgitation. The Pascal device, which you've seen at this meeting, is individually adjustable clasp and a spacer. I'll show you more of that in just a second. That's going to be evaluated for both degenerative and for functional MR, and of course, the valve replacement program with the cardiac AQ device, early feasibility, and in the RELIEF study, both for functional and for degenerative MR. But we've talked about some of these issues, and these issues really relate to the fact that functional AR clinical studies have to be performed on the background of guideline-directed medical therapy. And I think this meeting has been very good about showing all the advanced therapies that the patients were on before we moved ahead with the functional mitral regurgitation. And our studies will likely be compared to guided-directed medical therapy alone or guided-directed medical therapy with surgery. The other interesting component about all these studies is they're going to have very detailed core laboratory and CT review before they move forward into treatment of the patients. Incredibly important as we build that evidence base on imaging, because we really have to understand how these patients actually really respond. With respect to the patients, it's changing a little bit of a paradigm. It's not death and stroke any longer. It's how do the patients feel. And so in our clinical trials, we want to make sure the patients aren't too sick or extreme risk. We want to make sure that they can have some functional benefit. We want to make certain they're not too healthy and that they have more than 400 meters on a 6-minute walk test. And they need to suffer with shortness of breath with their mitral regurgitation. So our new clinical trial endpoints are going to not only include mortality, but they'll include functional indices such as rehospitalization, 6-minute walk tests, and quality of life indices. Now, we've talked very extensively about the important clinical benefits of the Cardioband. The Cardioband will be evaluated in the United States by the ACTIVE trial. Mark Reisman is the study chairman. Brian Wizenot and Vino Tharani are the PIs. It will be a 2-to-1 randomization of the Cardioband with guideline-directed medical therapy versus guideline-directed medical therapy alone, 375 patients. The patients need to have very broad inclusion criteria, and they need to have clinically significant functional mitral regurgitation, moderate to severe or severe. They have to have symptoms of shortness of breath, New York Heart Association class 2 to 4A, and they need to be hospitalized in the past year or have an elevated BNP, so they need to be really active with their disease. The primary endpoint's an interesting primary endpoint. It's a co-primary endpoint of the prevalence of less than 2+ mitral regurgitation and a hierarchical analysis of all-cause mortality, number of heart failure admissions, improvement in the 6-minute walk test, and quality of life using a Win analysis at 1 year. And the first patients have now been enrolled in this study. Pascal is a device that you've seen extensively at this meeting. The important part of this device vis-a-vis MitraClip is that there's individually adjusted clasps and a spacer that allows a larger grasping area with the mitral annuloplasty. And it's designed primarily for procedure simplicity. The CE Mark study will be with the CLASP study. That's going to be with the Pascal Transcatheter Repair System. In Australia, Canada, Darren Walters, Dr. Ing, Webb, Cohen, and Pham. And the leaders for this study in the United States will be Ted Feldman and Rob Smith. This will be multi-center, prospective, single-arm, non-randomized, inclusion criteria that include a mitral valve area greater than 2 centimeters as measured by perimetry, as well as our ability to perform a 6-minute walk test. And the primary endpoint for this will be a hierarchical composite of all-cause mortality or recurrent hospitalization at 6 months. And the status for this is also enrolling patients. Now, we haven't on this panel talked much about a very important therapy that we have with the Edwards Cardiac system, a full valve, transcatheter mitral valve replacement system that uses a unique answering system. And I think the primary advantage of this is that it sits high in the left atrium and it minimizes the degree of left ventricular outflow tract obstruction. We've learned a lot about the early feasibility study and the RELIEF trial with Dr. Sundergaard and multiple European investigators, multi-center, prospective, single-arm, non-randomized, currently enrolling patients, with the primary endpoint being freedom from major adverse cardiac events, cerebral vascular events, including MACE at 30 days, as a variety of other all-cause mortality, myocardial infarction, and stroke. In the United States, the early feasibility study is also actively recruiting patients. Howie Herman is the study chair, Rob Guyton and Jim Hilmer are the principal investigators. This will target 20 patients, primarily transeptal, because that's actually what our physicians in the United States prefer for this approach. Multi-center prospective, single-arm, non-randomized, certainly with a tremendous amount of learning that's going on with each case in this early feasibility study. Primary endpoint will be procedural safety, as assessed by the freedom from device or procedure-related outcomes at 30 days. Now, Dr. Nickening touched on the important work that's being done now in transcatheter tricuspid valve therapies with the Edwards program. We've talked about the Cardioband. We haven't talked much about the spacer. The unique challenges, at least in my opinion, for the tricuspid is that most of these cases are functional regurgitation rather than degenerative, resulting from an annular dilatation 40 millimeters in the septal-lateral diameters. We've talked earlier about that they're very thin leaflets with a very complex chordal structure. In fact, the septal chordae often attach directly into the septum. The concomitant pulmonary artery hypertension and right ventricular dysfunction is very, very important to consider as we go into these trials because those, in fact, may be the limiter to prognosis rather than the tricuspid regurgitation. We've got anatomic considerations with the AV node and the triangle of Koch and the right coronary artery. The echocardiography can be more difficult if the idea is a leaflet approach primarily, and of course all of this is complicated by prior pacemaker placements. You've heard in extensive detail from George Nickening about the tricuspid repair program. Alex and Dr. Nickening, Azim, any of the panel members here are on the TRI-REPAIR trial. I'm not going to go into much detail, but that'll be 30 patients. It'll be multi-center prospective single arm with the criteria that George talked about earlier, which was an annular dilatation of more than 40 millimeters and a systolic pulmonary pressure of less than 60. And the primary endpoint of this will be a variety of adverse events, as well as the change in septal lateral dimensions at 30 days. And you've seen those very, very encouraging initial results. The final part of the Edwards portfolio, the tricuspid, of course, is the Forma tricuspid repair system, positioned within the regurgitant orifice that creates a platform for native leaflet coaptation. It preserves all the underlying structures, but reduces the gaps between the leaflets, thereby reducing the degree of tricuspid regurgitation. The early feasibility study with the Forma investigators in the United States will be is being led by Raj Makkar, Vasilis Babaleros, Dr. Elig, John, and Kadali, 30 patients. Inclusion criteria are functionally significant tricuspid regurgitation and high risk for mitral valve repair or surgery, with the primary procedural outcome as procedural success at 30 days. And finally, the SPACER study, John Webb and a variety of Canadian and European investigators are now completing the SPACER study, 78 patients. Inclusion criteria, again, symptomatic tricuspid regurgitation, heart association, class 2 or greater, and high surgical risk. Primary endpoint of this SPACER study will be cardiac mortality at 30 days compared to an objective performance goal. So lots going on with this portfolio of devices. Now, what are we going to learn from this? I think a year from now, I hope we're going to be able to come back here and say which morphology is going to be best for which patient with which device. But we have to have rigorous trial designs. We have to have assessments that include patient-oriented outcomes and functional status, and I think that's going to shift towards rehospitalization, 6-minute walk test, and quality of life. The initial focus will be on very symptomatic patients with moderate severe mitral regurgitation, primarily at those patients who are at increased risk for surgery. We'll have to figure out early intervention for lower risk patients later. Right now, we're primarily looking at patients who are increased risk for surgery. Again, most of these studies are going to be performed on the background of guideline-directed medical therapy. So a heart failure specialist is now an integral part of all of our heart failure teams themselves. And so perhaps next year or the year following this, we can come back with a morphologically driven device selection for our patients, but we're only going to do that with very intensive imaging data, CT and echo, and very precise patient-oriented outcomes in order to understand best how these devices work in this sick group of patients. Thanks for your attention.
So thank you, Jeff. It was a great talk, and I think this concludes this session. And I guess you had the opportunity to observe that, well, we have still quite a lot to learn about pathophysiology of the secondary MR, but Francesco told us one message: intervene early, don't wait for dead ventricle. Then we heard about the treatment using this Cardioband mitral, and really, you've seen, can be done by Ralph within 20 minutes. For the other, a bit slower. It takes 60 minutes, but you can learn it in a very systematic way, set to a very good patient selection based on clinical ground, echo, and CT with a very standardized procedure, and you can control what you are doing on a beating heart. It is essential. Then you saw the results overall, very satisfactory, very promising. Of course, only few patients, only limited follow-up, but still very promising. And we have to continue on this track. We have to continue by doing new trials. We are continue by learning how to combine the different tools we have in order to try to reach the surgical perfection, the surgical tailoring of the best treatment adapted to the individual anatomy, pathology, and problem in dysfunction of the valvular apparatus. So all these things are extremely promising, and as Jeff said, next year it will be even better. So see you next year.